Black Doctors podcast highlights the stories of minority professionals with the goal of inspiring others. Season 2 provides more episodes and features a wider variety of professions. If you like what you hear, please subscribe and share with others, because the next generation can't be what they don't see. Tune in every Monday to hear our stories told by us.
Hello and welcome back to the Black Doctors podcast. This week I'm privileged to be speaking with Dr. Kevin Simon. He is a psychiatrist. He's currently finishing up a fellowship, or two fellowships rather, in child and adolescent psychiatry and addiction medicine at Harvard. He attended Morgan State University for undergrad, earned a medical degree at Southern Illinois University before finishing his residency in psychiatry at Morehouse. Dr. Simon, thank you so much for joining us.
Yeah, no problem. And just to clarify, Morehouse School of Medicine, because I know folks from Morehouse College, technically they're two entities, but I'm glad to be here.
So why don't you start by telling us about your day-to-day job as a psychiatrist and currently as a psych fellow?
Yeah, so I'd say it's rather broad. So within child psychiatry, I have different rotations that I go through, both inpatient, meaning like the inpatient psychiatric unit. Then there's the medical floor patients that I will sometimes consult on, and then I have my own like continuity clinic that I see patients individually. So child psych is interesting in that the patients really start from zero on up, and so early on in fellowship, we're seeing kiddos who are 2 years old, 4 years old, questions about delirium or questions about withdrawal. So it's been interesting from the inpatient and medical consultation side, given that Boston Children's, which is where I'm doing fellowship, it's a tertiary site. So we tend to get some of the more complex cases to us. And then in my outpatient, my youngest kiddo's 4 years old, and then all the way up until, young adulthood, 24, 25. And the cases or the diagnoses that I see are wide ranging. So the classical, generalized anxiety, major depression disorder, some of the more serious mental illnesses like bipolar disorder or schizoaffective or schizophrenia, somatic symptom disorder. So it spans the diagnostic spectrum, and then the interventions include, psychotherapy. So I love doing therapy, individual-based therapy with patients. And then there's the psychopharm or medication management, where we have a lot of different medications in our tool bag, I suppose, to try to treat some of these conditions as best as we can. So that's the child side. Then the addiction side, which is still based with children, although I'm not going to see any 4 or 5 year olds with addiction challenges. So that really starts with I'd say middle adolescent, so like teenagers on up. We see pretty commonly tobacco, or i.e. vaping, nicotine. So we still say tobacco because nicotine is a byproduct of that. And then marijuana or THC, cannabis. And then there is a slew of things that I'd say my patients teach me about that, I've read about in textbooks, but didn't necessarily know people who were using them, including hallucinogens, LSD, psilocybin, or magic mushrooms, quote unquote, ecstasy, opioids, like the opioid epidemic. Given that we're predominantly working with adolescents up into teenage years, we're inherently including families. And so it's usually the pediatrician or, just mom or dad are just, concerned about their kiddo. They were caught or the school notified them. And so we're trying to, intervene pretty early, because most people, give me a very long answer, most people that have an actual substance use disorder, undoubtedly over 95% of them started before 18. Wow. So we're trying to change that trajectory.
Wow. And I honestly hadn't thought about things as simple as nicotine, right? I'm thinking you're seeing all, heroin addicts and opioid addicts, but yeah, nicotine it does start when you're young, right?
Yeah. It's when I was in adult training, you classically, you're at a major public hospital. So I was at Grady. You're seeing the heroin, you're seeing cocaine. But if you get that history, like what was the first thing you started, most often it's probably alcohol and or nicotine. And so we kind of recognize that trajectory needs to kind of be halted earlier. So some of the options that we're trying to do is really just educate kids, and I mean sometimes they do need to be put on nicotine replacement because it's pretty difficult to stop, right? So before COVID, if we can remember that far, the major thing was like a volley or basically vaping related injuries, right? Yeah. Like that was a thing that was coming out in different states, even Massachusetts, where I am. We're putting bans on vaping devices, but then January, February hit, and everything was, COVID as it should have been. But so the vaping devices are problematic because you presume, or the kids think that they're not using that much, but then when we get the levels, they're equating to basically like a half a pack of cigarettes a day. Kids don't generally think about it that way. And so recognizing substance use disorders in kiddos, it gives you a different perspective, certainly, than the ones that we classically see when we're in adult training or in adult hospitals. And when you're seeing patients in your office, are these like 20-minute visits, 45-minute visits? How does the day-to-day kind of patient encounters work? Yeah, so when I'm wearing my true child psychiatrist hat, that is a new eval would be an hour and a half. And then a follow-up is anywhere from 30 minutes, or it could be an hour. So in our setting, we don't have like the 15-minute appointments. And then for the substance use clinic, every appointment is an hour. Whether or not the follow-up, it's an evaluation, it's an hour. And then actually our evaluation is actually about 3 appointments long. So we meet with the kiddo by themselves, right? Like without the parents, express the nature of confidentiality. Then we meet with the parents, and then we meet with them together to explain, like, hey, this is the condition that we think, he or she is struggling with, and then here's our kind of plan. So, but yeah, we give folks a lot of time. Because when you're talking with a kid and you're talking about mental health or addiction, that's not something that can just be quickly done in a short time span. So the older patients, they kind of can just get, they can tell us what we want to know or what they want to tell us in a pretty short time. But to build rapport with kids, you need some more time. Gotcha. So interesting. So when did you decide to become a physician? Yeah, so that was during college. So prior to college, I played basketball, and like most kids, had aspirations of at least playing in college or going to the NBA. And then I got a knee surgery. I tore my left ACL my junior year of high school, did some rehab, and I really thought I wanted to do physical therapy because it was like I was running on a treadmill underwater. It just was cool. And then got to Morgan, freshman, sophomore year. I was a bio major, thought about doing physical therapy, and at that time you needed to do like 100 hours or so of PT time, like, volunteer time. And so I can't remember the name of the clinic, but it was in Baltimore. And it was there I met the team physician for the Ravens. And up until that point, I had not known, I don't know why I would have known, I didn't know that there were like team doctors, right? Yeah. So I was like, oh, the team doctor, that's a cool thing. Just a subset of like opportunities came up. So there was a summer program I did in Michigan called Profile for Success at the University of Michigan, where they paid you to come to the campus and learn about medicine. And I thought that was cool. And then junior year at Morgan, there was 2 programs through the NIH. One was Mark U Star, and then the other was MBRS. I don't even know what MBRS stands for anymore. but both programs paid part of your tuition, and all you have to do, I say all you have to do, what you had to do was participate in doing some forms of research. And so it was really like that sophomore, junior year, kind of doing these opportunities and programs where I was like, oh, like people will pay you to think. And I thought that was good.
Yeah.
And then when I went to Michigan, actually seeing the different specialties, I was like, oh, I think I could do medicine. And it really was probably like my junior, senior year that I really committed to the idea of being a physician.
No, that's incredible. That's actually very similar to my story. I was a pre-physical therapy major and did the shadowing, and that's when I realized that I wanted to go into medicine. Mm-hmm. That's crazy.
Yeah, up until that point, obviously, we all have pediatricians, so we kind of see them, to get our vaccines, but I didn't necessarily just have like a cadre of physicians around to just say, oh, this is what you're doing. So yes, it really was college and getting those opportunities. And so after Morgan, between Morgan and Southern Illinois University, I did a postdoc program at SIU.
Okay.
And so that was another 1.5, 2 year period where it's like, okay, you really got to like learn to buckle down and learn how to learn, right? So like in undergrad, you can kind of figure out how to get an A, how to get a B in some of your courses. But if you're trying to go to medical school and you recognize, at least I had recognized that, I wasn't necessarily the most regimented student at the time. So those 2 years in Carbondale, where the campus is, were definitely helpful for me. So that's how I figured out medicine. And then in reference to going into psychiatry, mm-hmm. in med school, my first year came in and you hear about, oh, you gotta have research because that's what residencies are going to want. And at the time I didn't know, like, yes, I did the summer programs at Morgan. That's working in a lab on an undergrad campus that doesn't have a medical school associated with it. So I thought I wanted to do general surgery at the time. Why? I don't really know, other than it's like the thing you're supposed to do if you're a guy, surgeon, right? So just that's really what. So I literally emailed. This is crazy thing about it. I emailed maybe 15 or 20 like surgical departments, like just around the country. Like I'm a first year med student, and I'm looking to do research, right? Very, very, very naive.
Yeah.
And
how'd that work out for you?
It actually, so one program, University of Wisconsin, I'll never forget, University of Wisconsin, Herbert Chen, who at the time was the director for their general surgery division, who's now the chair of surgery at UAB. He emails me, says, hey, you want to have a phone call? I said, sure. And then he's asking me, like, what do I want to get out of the summer? And I said, what do students usually get out of the
Fair
summer?
Question.
And he's like, oh, we get, our students get maybe 2 posters and a publication. I was like, yeah, 2 posters, publication, that sounds good. And, I don't really know what I'm saying, right? I'm just trying to fake it till I make it, right? So I literally, it was May of 2011. We have our final exam. I pack up all the stuff that I have that I own, put it in my car, drive to Madison, Wisconsin, sublet a place, and for 8 to 10 weeks, I'm at the University of Wisconsin in like a surgical lab, doing like pipetting, Western blots, like nothing related to surgery. And it really was I would say like an inspirational period, because what I would do is I would meet with Dr. Chen every week about the progress of the project, and then just generally what I want to do in the future. And it's really, I would say he's the first person to plant the seed of, research could be a thing that you do, because he's like, yeah, I went to Duke for undergrad, and Duke, which it still does, I think their 3rd or 4th year, they can kind of do like a policy year or a research year. And he's like, yeah, I was doing HIV research, but that's not what I'm doing now. So this may not necessarily be what you do in the future. And so I'm not a neuroendocrine researcher, although I have a paper in it. But yeah, so now I am kind of, I'd call myself a little R researcher. But yeah, so that's what I did that first summer, which kind of, again, it gave me interest into research. But then it was really third year where you rotate through your different services. And the way we had it set up, I did psychiatry, then pediatrics, then OB-GYN, then general surgery, internal medicine, family medicine. And after psychiatry, my attending, Dr. Jeffrey Bennett, was like, oh, have you thought about this? I was like, no, I want to be a surgeon. And he would email me pretty religiously throughout the year. And I would say that I did enjoy, he had a, we'd call it a DD clinic or a developmental disability clinic, where he was like a master diagnostician in that he could meet and communicate with people who could not communicate, right? So you could think about the classic autism spectrum, averbal person, or, severe intellectual disability. And, they're coming in with their caregiver, and he could just somehow sense that there's something amiss or different. And I actually really did enjoy that clinic. And then I enjoyed all my services. Then I got to surgery, and this is the thing that I want to do. So I'm like, pumped up. I'm reading,
was it Savastin's?
Yeah. And I'm like staying up late. I got my little black book that I'm drawing in, and and this is why it's important about who you're paired with. The resident that I was paired with was probably the most unhappy person I have ever met, and just was not in. She herself was not that enthused about what she was doing, and so despite that I was like excited about it, I really never got the sense that they were as excited about me wanting to do what they're doing, rather than I was just like some appendage, like tagging along. And so later that year, I, was thinking about the surgery thing, and then thinking about psychiatry because he was emailing me. And then also that seed that Dr. Chen planted, I was like, oh, you know what? I hear people do like research years, and like what's needed to go into that. So I started Googling, and NIH had a research year, and they had different types. Like they had surgery, they had mental health, they had OB-GYN. And so I applied for two, one in surgery, one in psychiatry. And researchers from the University of Pittsburgh reached out to me, 3 different PIs, and one had projects, multiple projects. I was like, oh, that sounds good. That sounds cool. He's like, you want it? I was like, yes.
Wow.
So literally third year, I finished my rotations, and, my dean's like approving of it. I'm like, okay, I'm going to go to Pittsburgh for a year. And everybody in my class was like, but you want to do surgery. Why are you going to Pittsburgh to do psychiatry? I was like, well, I'm not sure when else I would have a year to be able to take some time for myself and see if this is something that I really want to do. And so, so I went to Pittsburgh, was there for a year, thoroughly enjoyed it. And really, that's when I started to recognize the impact of mental health from a individual and public health perspective, because I was working with like health economists about, service use. And so that's what really changed the trajectory to say, okay, I could be a psychiatrist, and a psychiatrist who's interested in research. And so, that then became kind of like my calling.
Wow.
And so, that's how I got into psychiatry.
No, that's incredible. 2 things I want to pull out of that. Dr. Chen, what was his heritage or ethnicity?
He was Asian.
Yeah. So, so often people think that our mentors and they need to look like us or be from a similar background, but oftentimes, you can get this help from anybody.
Yeah, I mean, if you just think about the numbers, right? So less than 5% physicians are Black or African American, right? So it's just undoubtedly that you're going to have mentors that come from other ethnicities and cultures. And what I would say is what really was nice about being paired with him or him reaching out was he showed his vulnerability. Meaning, if you like Google Herbert Chen, I think he's at UAB now, you're going to see a CV that is like impressive beyond impressive. Yet he would say, the reason that I'm here is let me show you all the rejection, grants that I have. Let me show you what they said. Let me show you what they said about me, when I was coming up. That is he really ready to be a PI? And so I think, here it is, nearly a decade later. I remember those conversations, and even myself, I just submitted a grant, right? If it works out, it works out. But if it doesn't work out, I also know that that doesn't mean that I'm not a good clinician. I don't have good ideas, because I see someone who's really at the top of their game, but they showed me their failures. So, I think it would be certainly challenging for a student, a pre-med or pre-professional student, any field, to try to only have mentors that look like them. Now, I do have a lot of Black mentors, and they're actually mostly female, because again, there's not a lot of us Black males in medicine. So, I think it's really important to have a broad, what I call mentoring team. You should not have one mentor, but a team of mentors.
Yeah. The second thing I want to pull from what you said is the impact on your timeline, because we get so wrapped up in comparing my timeline to his and to hers. And
yeah. So you're right, man. So my med school, the class is small. At the time, it was 72. And all 72 or 71 tended to do everything in 4 years. I would say, my mom would tell you, generally, I've had my own timeline of doing things. So at Morgan, it was my junior year, and I said, oh, you know what? I really like sociology. I want to get a sociology major. Oh, but that's going to cause me to be here an extra year. And I said, okay, that's fine, but I really like this subject. And my sister would tell me now, oh yeah, mommy called and was like, what is Kevin doing? And my sister, who was older, was like, oh yeah, students do this. But yeah, I think, and then in med school, having the year out, really, again, my sisters came in handy, because they were like, well, when else would you do this? Which is true. When else would I have an opportunity to just live in a different state just for a year, to just explore kind of ideas, right? So I always tell people, if you have an opportunity, study abroad, apply for something. The worst that can happen is you get a no, but the best that could happen is you get a yes and you get a good experience out of it. So being hooked up on timelines does not serve you well, particularly in medicine, right? So if I think about this, Morgan, 5 years, 2-year post-bac, that's 7 years, 5 years medical school, 12 years, 3 years for residency, because if you do child, you can quote unquote fast track. So we're talking about nearly 17, 18 years of learning, right? So if I viewed it as this has only been challenging, I haven't had great experiences, this would be a very long time. But along the way, I met my wife. We've had a daughter. I've met good friends. I've lived in different cities. I've had a lot of great experiences that really could only be afforded to me because of the interest in medicine and what medicine, could provide me. And so, I think you definitely, cause I had friends tell me at Morgan, why am I going to Illinois for a postdoc? Like they weren't in medicine, because they're just like, I'm going to work. I'm like, well, in order for me to get to med school, I have to kind of do this thing. And what I would say is I've been very relatively strategic about what opportunities I would take and how they would benefit me, right? So there are a lot of postdoc programs. Drexel has one, Ohio State. I mean, there's really probably over 50 postdoc programs. Why did I choose SIU's MedPrep is the name of it. It said during the interview, if you decide to go to SIU, we'll pay your tuition. I said, okay. I will I will do that. Now, what does that mean? That means I have to sacrifice potentially going to a Duke or a Case Western or some other more brand name schools, right? And some of my classmates did do that. They opted to go to quote unquote more brand name schools. And I was hopeful because they had a limited number of scholarships. And so I was like, oh, you're going where? Oh, yeah, awesome. Go there. Like, that's amazing, right? And then it came where I was on the list, and I was like, thank you, Lord. And so, yeah, so that helped us with tuition. And, I took out loans for housing, but that tremendously helped me from a financial standpoint. And, during residency, you can moonlight. So I've been moonlighting a ton to try to help pay those loans down. But, the year out for research, well, okay, oh, you're paying me. Okay, thank you. You're paying me. You're paying my housing side. I don't have to take an extra loan out. So all the things that I've kind of done have been strategic in terms of not also adding a burden of debt. 'Cause I think one of the things I know for sure I used to think about was like, oh, should I get an MPH before school, right? Like does it help my resume?
Mm-hmm.
Potentially for some people, it may help their resume to get an MPH before school or some other degree before school. And then some people will do it in med school. I then learned, oh, wait a minute. When you become a physician, right, the MD or the DO, people will then pay you to get the MBA, pay you to get the MPH, pay you to get the MPP, public policy. And so, yeah, I've been very strategic about, even if I am extending time in learning, okay, I am myself not paying for it. It's getting paid for somehow, some way.
Brilliant. That is absolutely brilliant. And I'm going to add to that, because in addition to you took this extra time, you have an amazing family, Dr. Brittany Halford, who was on the show previously, a beautiful daughter. But I think in part because of your vast research experience, you are extremely, extremely well published. Because when people will sit back and look at how does Kevin Simon have so many publications, it's because you're doing this extra research. I mean, you were recently in the New England Journal of Medicine. You've been featured on NPR, among other outlets, as an expert in your field. And all of this stems from you putting this extra work and time in. Yeah,
I mean, it's interesting. People will say, like, Kevin, where do you find the time? And I'm making the time all the time. Like I'm not rushed in the processes that I engage in, right? So the piece for the New England, a lot of people will say, I'm not a writer, meaning like, Stephen will say he's not a writer. That's not true, right? Like technically that's not true. I think everybody has a story. Everybody has a capability. I think what may be different for myself, I don't mind coming back to the horrible first draft that I put of ideas on a piece of paper, right? And I will keep coming back to that piece, right? So the New England piece, although it was published in, we're currently in December, it was published in November. The piece was written back in July, August, right? And then I submit it, and then there's reviewers, and they say, well, we don't understand this piece, or we don't understand that piece. And so what is that forces me to then take time to say, okay, how can I make this a little bit clearer? How can I make this more nuanced, right? But still keep my voice and what are the messages that I want to get across? But that takes being okay with taking criticism, right? Because I know that people aren't criticizing me, like Kevin Simon. They're saying, wait, this idea that you have, I don't understand. It's just not clear enough. So I have to, if I'm saying I'm an expert, I have to be able to explain things in a very clear manner, right? So that's the whole peer review process. Just now, I submitted a grant, right? There's a lot of critiques on the idea that I have, but I can't be mad that people are critiquing. I have to say, okay, how can I make this make sense for them, right? It's not enough for it to make sense to me. I have to make it make sense for other people. And so that's just, you have to work on your craft, right? So outside of being like an awesome podcaster, right? Like you play like 10 you play like 10 instruments, right? Like you practice that, right? Like you go back and you say, okay, how do I get better in tune? How does this lyric sound with this particular, that's what I do with writing, right? So I read I read a lot, but then when I'm always drafting ideas about concepts that I want to write about. And the reality is I know the idea that I have, it sounds good in my head, but how do I then translate to make it sound good to other people? And so there's the New England piece. There's other pieces that I have that aren't published yet, but I know, okay, I'm going to keep working on this. So I tell people all the time, like, you just got to be diligent about keep coming back to it. And so some people don't want to read their trash work, right? And that's okay. But for me, that's something that I don't have a problem with, trying to keep massaging the work, keep letting it metabolize in my head. How do I make this make sense? So that's something that I guess is a gift, if people want to consider it a gift.
No, that's incredible, man. You may be motivating me to start writing. It's going to take a little bit more motivation, but I'm thinking about it. Speaking of podcasts, though, so we are actually wrapping up season 2 of the Black Doctors podcast. This is you're the final guest on for this season. We're recording in December of 2020. This year has been an incredible year. It's a positive way of putting it. As we're looking forward to this new year, 2021, we're still dealing with the fallout of this COVID-19 pandemic. And I know this has had an incredible impact on people's mental health. What have you seen as a psychiatrist in terms of the impact of COVID-19 on mental health?
Yeah, so just have to pause on COVID. So it definitely has been catastrophic in the sense of, those that I see when I'm covering like adult inpatient units, people that are unfortunately homeless or displaced, underinsured, underemployed, are in a situation where they're definitely more stressed. The middle income families that I have patients, their parents are losing their jobs or have lost their jobs, and certainly trying to hold on to unemployment benefits when they can get them. And then kids just generally, in the beginning, back in February, March, it's cool to be home for a little bit and not have to go to school. But I can tell you by May, even though the quote unquote summer was coming, kids were like, I need to get out of the house, right? And parents are feeling it too. Like, what else can I do? One, because I don't even want them to be on this device all the time. So definitely we have seen an increase in anxiety, an increase in depressive symptoms, an increase in the emergency room visits for mental health concerns, both from the adult population at the adult hospitals I'm at, and then even the child mental health evals. So we know that there's a strain. And then also another population that I don't think gets thought about enough is those that have special needs, right? So again, if we're talking about autism, intellectual disability, usually those persons have special schools that they go to, right? And the idea that those schools had to be shut down because of COVID, now you shifted a whole cadre of people to be inside their house with parents that are not trained behavioral therapists, who are not trained ABA therapists. And so we definitely saw an uptick in our special needs population also coming to the hospital and being admitted because behavioral dysregulation kind of out the wazoo with the tension and the stress from the community coming into the home. So there definitely has been a worsening. I think as we're in December, and we're hearing the news about a vaccine, presuming that the FDA suggests, it's safe. I think I just recently saw that the former presidents will take the vaccine, live. I think as a community, as a nation, we can kind of recognize, okay, there is going to be an end to this at some point, but despite the vaccine coming in, we're still going to have to engage in universal practices like hand washing, face masks for a little bit until enough people, right? Because we need to have millions of people get this vaccine.
Right.
So I think recognizing that there is going to be an end is a positive. The fact that Christmas is coming up, even if you can't be with your family face to face, we have adopted, these virtual platforms that can be good. And then generally, I think the things that I've been telling patients is, okay, what can you do individually, like as a little bubble with your family that is outdoors, right? So families have been going to get their tree, right, for Christmas. Families have been going, so the Midwestern families and the West Coast families now, they can go to farms if the weather's permitting, right?
Yeah.
In the Northeast here, we can still do sledding when snow is around, right? So you can still do family gatherings in a safe manner if it's the bubble that you've been, circulating with these past 9-10 months. So I think we're nearing the end, given that the vaccine should be approved, and we have to hold on. And, with regards to seeking services, I think we recognize now that virtual platforms are great for therapy. The field of psychiatry and mental health has been providing virtual services for a long time now, very robustly. So I think people should and can reach out. If you have insurance, if you don't have insurance, there are providers who are wanting to service our community because we recognize the challenges that COVID has presented. But so overall, I think because it's going to be the new year, we're going to get this vaccine, we can start to breathe just a little bit more easier, knowing that help is on the way.
And I was hoping for some positivity as we look forward to this new year, and there it is. Appreciate you for coming on the show, Dr. Simon. For those that don't know, Dr. Simon does see patients and provide psychiatric care in Massachusetts and Georgia. That's where he has medical licenses. He's seeing those patients virtually. If you are interested in getting your mental health needs taken care of. Dr. Simon, how else can folks get a hold of you?
Yeah, so, folks can follow me on Instagram or Twitter at Dr. KM Simon. So that's DrKMSimon MD, Dr. Kevin Simon MD. And yeah, follow me there, publications, interviews, podcasts. And, if folks want to reach out, they certainly can email me by going on those platforms, and I'll try to answer questions as best as I can.
Kevin, thanks so much for joining us.
Yeah, no problem. Thank you, Stephen.
The Black Doctors Podcast is a nonprofit, volunteer passion project with the goal of inspiring all who listen. Tune in next week for another episode of the Black Doctors Podcast with Dr. Stephen Bradley, your friendly neighborhood anesthesiologist.